So today we'll be dealing with the vesiculobullous lesions of the oral cavity. Mainly we'll be dealing with pemphigus. So moving on to the vesiculobullous lesion, we should know what a vesicle is. A vesicle is an elevated blister containing clear fluid that are less than 1 centimeter in diameter. And bullae, it is an elevated blister containing fluid that are greater than 1 centimeter in diameter. Now, moving on to the main vesiculobullous lesion, that is pemphigus, we'll be dealing with introduction, types, the differential diagnosis, and management. So, coming to introduction, pemphigus is a serious chronic skin disease. It is characterized by the appearance of vesicles in bullae, small or large fluid-filled blisters that develop in cycles. Pemphigus is derived from the Greek word pemphix. So, what are the types of pemphigus? Mainly, there are four types, that is pemphigus vulgaris, vegetans, foliaceous, and erythematosus. So, these are the pictures showing the severity of pemphigus vulgaris in the oral mucosa as well as the skin lesion. Pemphigus vulgaris, it is a rare autoimmune disease that causes painful blistering on the skin and mucous membrane. Pemphigus vulgaris affects the mucous membrane which are found in the mouth, throat, nose, eyes, genital, and lungs. The disease usually starts with blisters in the mouth and then onto the skin. So, what is the main etiology of pemphigus? That is the immune system. This immune system usually produces a protein that is called as the antibodies. The antibodies normally attack the harmful foreign substance such as bacteria and virus. Pemphigus vulgaris occurs when the immune system mistakenly make antibodies against proteins in healthy skin and mucous membrane. So the antibodies, what it does is it breaks down the bond between the cells, and so the fluid collects between the layers of the skin, and this leads to blisters and erosions on the skin. So the precise cause of the attack by the immune is not known. Very rarely, certain medications can also cause pemphigus vulgaris. So it is seen in the fifth to sixth decade of life that the male to female ratio is 1:1, and with whites more commonly affected. And the size is thin-walled bullae or vesicles, varying in diameter from few millimeters to several centimeters, and it arises in the normal skin or mucosa. The signs are these lesions contain a thin watery fluid shortly after the development, but this may soon become spirulent. That is, it becomes filled with pus. The most pathognomic feature of pemphigus is Nikolsky's sign. That is, after the application of the pressure to an intact bullae, the bullae will enlarge by extension to apparently normal surfaces. Another characteristic sign of the disease is that the pressure to an apparently normal area will result in the formation of new lesion. And this phenomenon is called as Nikolsky's sign, and it is resulted from the upper layer of skin pulling away from the basal layer. It is caused by prevesicular edema, which disrupts the dermal epidermal junction. So this is how you do a Nikolsky's sign. When a pressure is applied, it either results in the formation of a new bullae or it results in the extension of the lesion. So what are the sites? The initial lesion most frequently occurs on the buccal mucosa because the epithelium demonstrates less intercellular substance and fewer intercellular junction. So that makes the area more susceptible to acantholysis, that is the loss of intercellular connection. The palate and gingiva are other common sites involved. The oral lesion begin as classical bullae on non-inflamed base, the formation of shallow ulcers as the bullae break rapidly. So usually we see an ulcer, the patient presenting with a symptom of an ulcer rather than a bullae. Nikolsky's phenomenon, the oral lesion may exhibit Nikolsky's phenomenon and may be denuded by peripheral enlargement of the lesion. The lesions bleed easily and these are tender on palpation. The pain may be so severe that the patient is unable to eat. The thin layer of epithelium peels away in an irregular pattern, leaving the denuded base. So, what is a differential diagnosis? If a proper history is taken, the clinician should be able to distinguish between the lesion of pemphigus from those caused by acute viral infections. In pemphigus, the same lesion continued to extend peripherally over a period of weeks to months. In early stage of the disease, the sliding away of the oral epithelium resembles skin peeling after a severe sunburn. So you have to differentiate between a thermal burn, sunburn, and a peeling away of the pemphigus. So, how do you manage it? An important aspect of patient management is early diagnosis. Management varies according to several factors, including the severity of the disease and the speed at which the disease progresses. The mainstay of treatment remain high dose of systemic corticosteroids, usually given in the dosage of 1 to 2 milligram per kilogram. Prednisolone is used initially to bring the disease under control, and once this is achieved, the dosage is decreased to the lowest possible maintenance levels. There is no accepted treatment for pemphigus confined to the mouth, but 1 year follow-up study of the treatment of oral pemphigus show no additional benefit of adding cyclophosphamide or cyclosporin to prednisone versus prednisolone alone, and it showed a higher rate of complication in the group taking the immunosuppressive drug. So the mainstay of treatment now is prednisone, and this is a chronic skin disease, so it takes time to resolve and it appears in cycles also. So with this, we'll conclude with a session. Thank you.